chairperson for the introduction as well as the invitation from the organizer. So thanks for the previous two speakers that sets the stage. And so what to do when there is positive troponins. So basically, I'll start off with my presentation. So I don't have any conflict of interest. Okay. So bear in mind that we are still using the same old fourth definition of MI, and probably next year we will come up with a fifth universal definition of MI, and then hopefully this will give us a little bit of clearer picture on how to deal with a lot of raised troponin in ICU. Okay, so this is the same slide that was shared by the previous speaker, and I think the most important thing is basically how do you determine whether this patient has injury or ischemia. So I think for acute versus chronic is pretty easy. So you check in terms of the variation of 20% in terms of troponin level. So if it is more than 20%, then you will classify as some form of acute myocardial injury. And always the gatekeeping is whether you can demonstrate ischemia in terms of the patient's profile. Okay, so this is a very kind of clear definition that is kind of published from the fourth universal definition of MI, and I'm sure everyone knows. But the problem is for type 1 MI, you really need to identify in some form or another in terms of you need to demonstrate as a chronic thrombus by angiography, or worst case scenario during autopsy. And for type 2 MI, it's something that we face a lot in the critical care setting, as you need to demonstrate that whether there's some form of imbalance between myocardial oxygen supply and demand, and this is unrelated to underlying acute coronary events. And if you look properly in terms of the criteria, they share the same setting. So in terms of symptoms, ischemic ECG changes, development of a neurogenital motion and things like that. And we know this is something that's pretty common, and with all patients that are admitted, I would say almost all patients that come to ICU, they will get troponin anyway, regardless of the symptoms. And we know that whether or not we are going to act on it is a different story, but prevalence of raised troponin in hospitalized patients is pretty high. So it's about, from registry, it's about 2 to almost 25% to 26%. So this table, I would say, it's something that we know. There's a lot of overlap in terms of what are the risk factors or what are the causes of cardiac and non-cardiac conditions. They can really upset the balance between oxygen supply and demand in myocardium. And these lists are really non-exhaustive, and both can sort of coexist in both type 1 versus type 2 myocardial function. So what happens next? Sadly to say that mortality is pretty high. So type 2 MI patients has high mortality as compared to type 1. And this is even so even if you adjust that for age, sex, or even other stuff. But for cardiovascular mortality wise, they are kind of similar throughout the median follow-up of 5 years. And this has been published in the circulation. And we know type 2 MI is bad, but how bad it is. So generally, if you look at the curve on the top, so type 1 MI, if you look up to about 1 year, 15 to 20%, then you have some form of mortality. But for type 2 MI, it's really bad. Okay, so those patients that has arrhythmia, anemia, hypertension, they tend to succumb really early, and sometimes they do not survive even at the end of 1 year. So these are bad signs and bad kind of prognostic markers for patients that has a type 2 myocardial function. So we know that if you tease out the type 1 versus type 2 MI, we want to know whether they have kind of a mortality due to underlying coronary disease. And in fact, if you look at type 2 MI, most of the time they will pass on or succumb due to the underlying condition, which is sepsis, in terms of whether underlying comorbidities and things like that. So if you look at this chart prospectively, if we know that if you have more risk factors, so the patient has a combination of hypertension, hypoxemia, anemia, tachycardia, so they would really have very bad prognostic outcomes. They will pass on, sometimes even in ICU or in the general ward. And the cumulative incidence really goes up when the more combination of risk factors that the patient has. So prospectively, so even if the patient survived the initial hospitalization, so what's happened next? So if the patient admitted with type 2 MI initially, more often than not, you get type 2 MI in the subsequent admission, and these are also bad. And for patients that came in with a type 1 MI initially, more often than not, they will end up with a type 1 MI in the subsequent hospitalization, be it from ACS or underlying myocardial infarction or heart failure. So this is a very nice JAMA paper that really tells us that for type 1 MI, which is something that we know, that you tend to have more ECG changes, you tend to have more left of the branch block, more ST segment elevation to kind of attribute it to type 1 myocardial infarction, and hence you have basically a lot more coronary artery disease as compared to type 2 myocardial infarction. Okay? So the thing is, what's the impact? Is there some problem if we sort of diagnose type 1 or type 2 MI kind of classify it wrongly? So there are. So this is going to be published soon in JAC. So this is a kind of a thing. So they educate all patients has type 1 MI, and you'll be surprised that almost less than half the patient is actually type 2 MI, and about 10% is just really having a myocardial injury. So these are things that, in terms of their vision, is something that we need to really look into it properly, because if not, we are going to sometimes dedicate a wrong treatment for the patient. So next come on, we know myocardial injury or type 2 MI are pretty bad, are harmful. Is this really a diagnostic problem? Is there a risk score that we can use? Or how do we differentiate reliably in clinical settings? So this is a very elegant white paper that was published 1 year after the 4th universal definition of MI came out. So essentially, it's basically boiled down to how the physician in the ground, when we are seeing the patients, in terms of the probability whether this patient is having type 1 or type 2 myocardial infarction. So it really boils down on the clinical acumen of this patient. And basically, you look at, other things, let's say you look at patient's history, physical findings, ECG changes, and hence whether you subject this patient to non-invasive assessment. So these slides really tell you what are it's the same paper, so basically it just tells that whether, from the clinical grounds, whether you think this patient has type 1 MI based on the clinical assessment, whether you find a clear triggers for type 2, or whether this patient has underlying known coronary artery disease, and you really stratify the patient based on what you can tell, and what are the risks of investigation and treatment that you kind of can tell based on the patient's clinical setting. And what about troponin? We heard a lot from the first speaker on the troponin. So does the peak troponin tells you whether this patient has type 1 or type 2 myocardial infarction? So essentially, it's hard to say. The first picture on the left, it really, from the ground perspective, it really looks at that if the patient has type 1 MI, the mean troponin is really higher than the type 2 versus myocardial injury. But after a couple of years in terms of the long-term study, to be honest, that the level of troponin or the value of troponin in terms of peak troponin does not really tell you much. It does not really tell you whether this patient has type 1 or type 2 myocardial infarction. And some analysts have even try to tease out whether if you measure TROP-T, TROP-I, or whether the ratio matters. So in fact, it really overlaps. Your peak troponin, your delta troponin, or which troponin that you use, we can't tell, tease out type 1 or type 2 reliably. So next come whether we can measure the troponin in a different context. So can we measure the complex troponin? Can we track the TROP-T, TROP-I combination, and whether we are able to tease out? And to be honest, those biochem data tell us you can't really tease out type 1 or type 2 based on the method of measuring the total troponin. So because of all these conundrum, ESC published this in their journals. So why are clinicians unhappy? Because you can't really tell, because to tease out whether this patient has type 1 or type 2 reliably in the clinical setting. Because in order to reliably tell whether this patient has type 1, you really need to get all the information. And sometimes, in order to do that, we have to subject all patients for cath. which is we know is not going to be something that we are going to do clinically as well as ethically. So these scores, as cardiologists, we love this scoring, right? So are there scores to tell you whether this is a type 1 versus type 2? So they are, but in terms of that, so the chart on the middle tells you that to kind of tell whether in terms of some scoring, whether you can tease out whether this is a type 1 or type 2. But comparatively, the TIMI and the GRACE that we know traditionally actually is pretty modest. And probably the TIMI and GRACE probably tell you more a bit in terms of mortality, but it does not really tell you much subsequently. So this is a very kind of a public study, the demand MI study. So it's not really a trial. It just get all patients that comes to the hospital with type 1 versus type 2 MI, they basically get anatomy. So basically they will either have or do a CT on these patients. And bearing in mind there's a bit of selection bias here. So we can find that there is close to about 2/3 of them has some form of coronary artery disease, and close to 1/3 of them have some form of obstructive CAD, and about 1/3 of them has some form of left LV systolic impairment as well. So this is also another follow-up study. How about if you can't have them, can you just CT everyone? So CT all the patients that's coming with raised troponin. And the only determinant in terms of telling whether this is a type 1 versus type 2 is if you can find low attenuation plaque. And there is a bit of risk, the hazard ratio is about 3 in this kind of setting. So this is something that we can try to basically if you find LAP or low attenuation plaque, so something that we can consider. So we go back to the same questions. Whether this patient has a type 1 versus